Good afternoon and welcome to the inaugural School of Medicine Grand Rounds. This event is built on the foundation of our departmental Grand Rounds, which are important to the success and to the fabric and culture of each of our departments. They, as groups of faculty and leaders, really make up the foundation of our School of Medicine. And so we wanted to create a school-wide Grand Rounds to build up on that momentum and that foundational thread of our culture that lives in our departments. This new series will be probably quarterly, but it will be broad in nature versus disease-specific or topical related to any specialty. So it will be broad and hopefully attract a universal audience. So we hope you'll continually join us for our quarterly Grand Rounds because we think the topics and the speakers will be quite timely. This first Grand Rounds I heard in one of our departments, and I was impressed by both the presenters, but the relevance of the material to the world we live in today. In our pursuit of an inclusive environment and a culture of excellence, I thought this would be an appropriate topic for us to begin in the context of cultural complications. I'll turn the floor over to Dr. Herb Chin, Chair of the Department of Surgery.
Thanks, Dr. Vickers. And I have the honor of introducing our speakers. But before I do, I'll want to introduce you to Colin Martin, who is our Vice Chair of Diversity, Equity, and Inclusion, who recently rolled out the set of cultural complications in our department, just to say a word or two about the rollout in surgery. And I think that he'll be available to take some questions at the end as well. And then after Colin, you say a few words, I'll introduce our speakers.
Thank you, Dr. Vickers and Dr. Chen, for this opportunity. Several months ago, close to a year ago, the work that our speakers have accomplished has become to recognize both nationally and internationally. Our department chair, Herb Chen, had a chance to host a webinar given by our speakers, and we subsequently hosted them in our departmental Grand Rounds. And to fast forward, we had the opportunity and the privilege to unroll this curriculum to our department and faculty. We have this cultural complications program monthly. We've had 2 so far, and they've been really well received. We've had record attendance at our morbidity and mortality rounds, and more importantly, we've had important discussions and growth around these topics. I really look forward to further hearing from our speakers. Thank you very much.
Thanks, Colin. So to introduce our speakers today, Chelsea Harris, Dr. Chelsea Harris earned her bachelor's degree from Brown University and her medical degree from the University of Vermont. She is currently a resident. That's right, she is a general surgery resident giving Grand Rounds at Maryland, but then she did complete a 2-year T32 research fellowship, obtaining her master's in health services research at the University of Michigan, where she interacted with Dr. Dossett. And hence the combination of the 2 of them giving Grand Rounds today. And when she finishes her general surgery training, she'll begin a fellowship in plastic and reconstructive surgery at Johns Hopkins. Chelsea is already nationally and I would say internationally recognized for the work she has done in leveraging social media for research dissemination. She served as a creative director for the Annals of Surgery and then is currently the creative director for the American Journal of Surgery. And she's really pioneered methods for creating infographics in real time, in addition to her work in disparities in health services research. Lesly Dossett earned her undergraduate degree and medical degree from Vanderbilt. And then after completing a residency, basically went into active duty in the United States Navy, where she served as a staff surgeon in various stateside and combat operational zones. After leaving the Navy, Dr. Dossett then did a surgical oncology fellowship down at the Moffitt Cancer Center, and then joined the faculty at the University of Michigan in surgical oncology. In addition to serving as the vice chair of faculty life for the Department of Surgery, she was recently appointed to be chief of the Division of Surgical Oncology. And Dr. Dossett has some Alabama ties as her spouse is from Birmingham. So We promised both of them a visit to Birmingham when we are out of COVID, but they were so nice to agree to give this grand rounds virtually. So Doctors Harris and Dossett, I'll hand it over to you.
Well, thank you all very much for the very kind introduction, and thank you for inviting us to share our work today. We are very honored to have this opportunity. So before we dive into the why, how, and lessons learned, I think it's important to acknowledge my own context. I have no financial disclosures, but as you can all see, I'm a white woman. I grew up in a small town in Vermont, as showcased here by my high school yearbook, that was about as homogenous as they come. In fact, to be totally transparent, I only really started paying a lot of attention to DEI work during my surgery residency when I found that my gender was playing a bigger role in my interactions with my patients, staff, and attendings than it ever really had in my own conception of myself, and in many respects, in more ways than I wanted it to. In other words, I started paying attention once it started impacting me. Thankfully, with the help of some really excellent teachers and some deliberate self-education, I've since broadened my scope. But I want to start with this to defray any beliefs that you can only join this work if you have perfect motives or you know all the language or have the lived experience. I constantly feel inadequate and uncomfortable in this space. I have to learn new things and I face my mistakes all the time. But the point, like everything in medicine, is to learn to do better. So with that said, the question becomes, should diversity, equity, and inclusion matter to healthcare workers? Ostensibly, no one here is struggling with a surplus of time. And we've all been trained to deliver the same standard of care, regardless of the patient in front of us. And we all strive to be moral, ethical people. So shouldn't that be enough? Well, as demonstrated in these articles, there are those both inside and outside of medicine that feel that physicians should focus exclusively on the quote unquote hard sciences and leave issues of diversity, equity, and inclusion out of it. As you can imagine, given the title of our talk, we feel differently. And as Doctors Vickers, Chen, and Martin have also outlined, this is because inequality and bias have clear ramifications for our patients and ourselves. At the physician level, studies consistently demonstrate that minority identity, be it race, gender, religion, sexual orientation, ability, etc., contribute to disparities in access to mentorship, nomination for awards, evaluation of competency, autonomy in the OR, salary, startup packages, NIH fundings, and endowed chairs. The list goes on, and new studies repeat this pattern seemingly every day. So researchers are just beginning to undertake the kind of large-scale studies that will be needed to examine the relationship between experiences of bias and discrimination and their links to burnout, attrition, or poor health. But it makes intuitive sense that these concepts would be related. And I think at the very least, these studies make it quite clear that our ideas of a neutral or an empiric meritocracy need intense scrutiny. And that if we want to create a healthcare workforce that reflects the population it serves, we need to take these concepts seriously. Inequality and bias in healthcare also have critical implications for our patients. In its landmark report, Unequal Treatment, the Institute of Medicine suggests that patients and physician concordance may be a key element of addressing longstanding disparities in care faced by minoritized patients. Though the data are admittedly mixed, some studies demonstrate that gender concordance results in higher rates of preventive screening, while racial concordance engenders more patient trust and closer adherence to medication regimens. In fact, in one recent high-profile article, the researchers found that Black infants who face a mortality rate 3 times as high as that for white infants had a 53% reduction in mortality penalty when cared for by Black physicians. The benefits of fostering and promoting diverse teams may also extend beyond direct patient care. As Dr. Melina Kibbe details in her illuminating talk, When Mice Are Men, the vast majority of research published in top-tier surgical journals is conducted in male animals or on male cells, despite the fact that we know that differences exist in hormonal milieu, body composition, presentation of illness, and side effect profiles by sex. In fact, 80% of the drugs that have been removed from the US market are removed because of a greater risk of serious adverse reactions in women as compared to men. Similarly, as we are seeing play out in front of us in COVID vaccine trials, large-scale RCTs are often very male and very white, and this is likely very strongly influenced by our constructs regarding who is supported in designing, recruiting, and publishing research. Taken together, these studies paint a clear picture that DEI, diversity, equity, and inclusion, should not be treated like a fluffy afterthought in our training, but rather the cornerstone around which our educational, research, and clinical missions are built. Of course, this is a tall order, and as many hospitals are finding out as they rush to fill this void, there isn't a clear blueprint about how to start. So as we began to conceptualize how we could improve culture and build allyship, we started with this fundamental question. Why does diversity training fail? And as we reflected on our own experiences, and data from the business sector, we began to identify some emerging themes. First, so much as just a check the box online module, which everyone hates. I care deeply about this topic, and my primary goal when doing an online module is to click through as quickly as possible. And I think the crux of our collective hatred towards online modules is that we can recognize they lack authenticity. We're all savvy consumers, and we can readily tell the difference between a genuine investment in culture and some tick box that a nebulous outside force has decided we needed to check. We also contend that any information that online modules might confer is at best transient. While the intent behind these modules may be best characterized as something is better than nothing, in reality, this approach breeds resentment and disengagement. Another issue is that example-based curricula can be alienating. I can't tell you how many cultural trainings I've attended aimed at a mixed group where every example of bad behavior uses a surgeon. And now, I won't claim that I've never seen a surgeon behave badly in the wild, but when the whole training focuses on how one group is the problem or the aggressor, it's very easy to flip from a receptive to a defensive posture, and the message gets lost. And this happens when discussing any line of difference. Similarly, trainings often focus on the extremes. And while manifestations of overt racism, such as while manifestations of overt racism certainly occur, subtle displays of bias, such as failing to recognize a woman or a person of color as a doctor, are in fact far more common, and in some ways harder to address because it can be challenging for recipients to parse out whether actual discrimination is occurring or if they're just being sensitive. This can also make reporting or calling attention to this behavior challenging, as offenders often aren't conscious of their mistakes, and recipients can feel like reporting could be seen as overreacting. Training that doesn't speak to this reality therefore misses a major aspect of the problem. DEI training also tends to come in single big chunks in the form of annual retreats or seminars. And let's face it, it's hard to hold anyone's attention for a whole hour or a half day. And without constant reinforcement and re-education, it's hard to sustain change. Our experience has also been that training is often not actionable. There's a lot of awareness raising, but what to do next is often much murkier. Furthermore, if all the strategies focus on those extreme, egregious events, and these don't occur often, training also loses its potency. Furthermore, as is denoted in our very titles, much of the education focuses on trainees because our time is more accessible. And of course, it is important to train residents and students, but culture is often a top-down affair. In the very hierarchical medical environment, setting the culture and the degree to which a department invites or promotes change often stems directly from the leadership. This gets back to that genuine investment. Do you see your leaders buying in and practicing what they preach? If your education focuses exclusively on the people who are least likely to affect change, your intervention starts falling apart. I've also found that in many of the voluntary DEI activities I have attended, there's a lot of preaching to the choir. That is, the people in the room already believe in the cause and are the ones doing the work, and the people who need to hear the message are nowhere to be found. So what do we do with this conviction that clinicians cannot provide the standard of care without understanding patient context, and that a tremendous amount of diversity training does not meet the needs of the people it seeks to inform? Well, our breakthrough and real stroke of insight came in asserting that we needed to address instances of cultural breakdown with the same rigor we applied to medical error. And with that, the idea for the Cultural Complications curriculum was born. Our idea, which you can learn more about on our website, was that once a month, in place of a standard medical or surgical complication, we would present an instance of cultural breakdown and discuss it in a similar fashion. To our minds, leveraging M&M was potentially really powerful because the format would be familiar to the audience and its rigor was widely accepted. The combination of case presentations, didactics, and group discussions was ideal because it would raise awareness that DEI issues were neither abstract nor isolated to the ever nebulous outside hospital, but a reality for the patients and the providers in our buildings. The didactics would establish a shared scientific basis, and the group discussion would help to establish best practices. We also felt like M&M was an ideal forum because it could be longitudinal and because it was one of the few places where all levels of the departmental hierarchy, from students to the chair, congregated. So the foundation of the curriculum is a PowerPoint-based curriculum that introduces 12 core topics in DEI, though we do aim to make it highly customizable to the local environment. Each didactic session defines the key terminology, reviews foundational science and where it exists, evidence-based response strategies. And in an effort to reflect the reality of the science, each session includes an explicit acknowledgement of the presented data's shortcomings and the context in which the studies may not apply. Finally, each module is fully scripted, so presenters require minimal a priori familiarity with a given topic, and each presentation can be delivered in under 10 minutes. Like traditional M&M, the cases are the heart of the curriculum. The case bank includes hypothetical scenarios that draw from contributors' personal experiences, existing literature, and social media. We purposely selected a range of perspectives and perceived levels of harm to include only the ones that were the most egregious. And we have several aims with this approach. First, by having a standardized case bank, we hope to avoid any of the accusatory overtones that may occur if specific events are discussed. At the same time, we hope by closely mirroring real events, we can reflect how cultural complications manifest in everyday life, and that by giving people space to discuss similar experiences, will raise awareness that this kind of behavior is both not acceptable and decrease its overall incidence, and help the group just develop strategies to respond better. Of course, this has not been perfect, and over the last year, as we have piloted this over at both the University of Michigan and the University of Maryland, we've learned a lot. First, I would encourage everyone to know your gatekeepers and invite them in. Thanks to some great clinical champions, it sounds like the rollout at UAB in Michigan has been pretty smooth, but my experience is a lot rockier. Most notably, when I opened up our inaugural session for questions, the first one I got was, why are you wasting M&M time with this? And as demonstrated at UAB, you have tremendous support from some of the true giants in the field, but every institution will have detractors. And if you can find these people, particularly if they are people in prominent positions, and invite them to be part of your team early on, you may prevent that kind of background noise that will undermine your efforts long-term. I would also encourage anyone engaged in this work to have real conversations with their skeptics. One of the mistakes that I made was that I thought in the lead up to deployment that notifying emails were enough. And they categorically were not. You need to actually talk to people, put yourself on their calendars, show them what you plan on doing and why. And if you don't, you risk moving what might have been a private conversation into a very public one. You also have to be willing to adapt. A silver lining of one of our confrontational debut was that once I sat down with my critics, one of the primary concerns that came to light was that the curriculum was focused too much on the provider experience, and M&M was a time for patients. So I was able to say, okay, I can find more studies, focus the data in new directions, and shift the scenarios away from physicians to center patients instead. And I don't pretend that in some of the darker moments and more exhausting times of residency, there weren't instances where I wanted to just stomp my feet and say, we should do it my way. But if you're unwilling to compromise and bend to include your critics, you may end up being shut out entirely. And if I hadn't done this, I would have missed a really excellent opportunity to broaden the curriculum and to include a patient-focused track and make it applicable to more institutions. And I think this lesson holds true in many efforts in diversity, equity, and inclusion. There are also less confrontational ways that we needed to adapt the organizational needs. At Maryland, the concept of implicit bias or microaggression was fairly new to a lot of the audience, so we really needed to build a common knowledge base before we could discuss a lot of the cases. In contrast, the surgery department at Michigan had been talking about these topics for years. So when they started, they wanted to spend less time on the didactics and more time on the case discussion. With this in mind, that we give the fully scripted curriculum to everyone who requests it, we encourage local leaders to adapt it to their specific environments and shorten or expand portions as necessary. We also had to be really mindful about how we cultivated participation. We recognize that initiating discussion on thorny topics can be tricky. So although each of them comes with suggested prompts, we do suggest that early in deployment, you may want to let some allies know about what the sample cases are ahead of time so they can prepare their thoughts and jumpstart the discussion. This is not to create a propaganda machine, but depending on how formal your M&M may be, having people who are prepared to speak up can really break through some of the initial ice. It's also important to understand your ask. Unfortunately, academic medicine remains a pretty homogeneous environment. So when you're talking about issues of diversity, equity, and inclusion, the natural tendency may be to draw on the same people over and over again. And this repeat sampling is taxing in and of itself, but as we discuss in our module on gender schemas, success in academia is often tied to conforming to agentic white hetero-cis norms. So asking members of your community to highlight aspects of their identity that they may have actively tried to downplay can be unfair and in some environments unsafe. Furthermore, being expected to be the voice of your population, the Lorax who speaks for the trees, is extraordinarily difficult. So as we continue to evolve and expand the curriculum, we continue to wrestle with some core questions. One of these, which the Michigan experience has highlighted in particular, is how can we holistically support our participants? Bringing up instances of discrimination in a public forum, asking people to tap into their trauma, and not always having a great response strategy is a challenge. 20 minutes is not a lot of time, and some participants feel that they've opened up painful wounds and then are expected to go right back to their clinical duties without a lot of follow-up. We are still working on how we can fix that, whether it be identifying faculty members who have volunteered to continue the conversation offline, additional evening sessions that might be voluntary, or perhaps everyone's favorite online resources. But I encourage anyone who wants to implement the curriculum to put some thought into that process as well. One of the other questions is, how do we evolve this to the Zoom platform? There's some inevitable awkwardness that comes with video chat, but there may also be some unique opportunities. For one, anonymous polling functions that can ask, has this ever happened to you? May allow participants to endorse experiences that they may not have felt comfortable admitting in public by raising their hand. Although it may take some moderator finesse, chat functions also enable participants to ask questions that they may have been too worried to ask out loud, or allow multiple people to share response strategies, particularly if they're more junior and wouldn't typically speak up during M&M. Another question that we return to again and again is, where should we fall on the advocate to impartial spectrum? Ultimately, we've decided that the most progress will be made among people who may be somewhere between sympathetic and unsure how to act to slightly skeptical of this whole idea. And this means that we have largely avoided moralistic or social justice language in the didactics, because there's some evidence that such an approach can cause disengagement. In other words, we try not to make the case that improving DEI is the right thing to do, but rather illuminate why it's the smart thing to do. However, there are certainly people, many of whom are in fact at the forefront of this work, who contend that if we believe that systemic issues like sexual racism are at the heart of this disparity, then any intervention that fails to speak to this reality misses the root cause and thus will be partial at best. And they may very well be correct. On the other hand, even in attempting this more neutral position, I've gotten feedback that I'm being too preachy or too threatening, and that may also be correct. Or it may speak to a reality that we might not be able to strike the perfect tone for everyone. One of the other core things that we've struggled with is, how do you educate yourself or your group without pretending to speak for someone else? For example, we have a module on intersectionality. That is the idea that being a woman of color brings with it a set of compounding challenges that are different than those experienced by just women or just people of color. As I have explained, I don't really have an intersectional identity, so when it came time to present that module, I was worried about the line between raising consciousness about the concept and being the voice of someone else's experience. What I ended up doing in that situation was reaching out to members of my department and inviting them to engage to the extent that they wanted to. And as I build new modules, I try to get critiques from people with lived experience, a nothing about us without us approach. But again, this places the burden on the very people contending with bias and remains an area that I still have a lot of trepidation in. I also wrestle with whether I should be allowed to turn it off. In the pursuit of this work, I've cultivated a lot of my social media, journal alerts, etc., to be around these topics. And there are days when it can feel so dispiriting to read about harm after harm. It's also hard to reckon with how your own group may have played a role in perpetuating some of these harms. The reality for me is that white women have not always been good allies. And while I think it's absolutely imperative to learn about what your group has done and how we can do better, that doesn't mean it's easy. I really wrestle with whether it's okay to turn away to recharge and the privilege that's wrapped up with even having that as an option. Because I admit that while it's hard to learn how you may have done a bad job, it's infinitely harder to bear the brunt of people doing a bad job. And I don't have any good answers on how to balance lighting a spark while avoiding being burned up by it. But to end on a happier note, if you will indulge me, this project also has taught me some great lessons and demonstrates time and time again about just how much good mentorship matters. Besides just being phenomenal people in their own right, Dr. Dossett and Dr. Dimmick have really done an exemplary job guiding me when I've asked for help, and of course, making that ask feel comfortable, while simultaneously giving me the freedom and trusting me to make a worthy project. Furthermore, they've both championed my work and given me credit at every opportunity, and the fact that I even have this opportunity to speak with you all today is a tribute to that. Finally, they continue to teach me that there is enough sunshine for everyone. And Dr. Dossett and Dr. Dimmick have been tremendous models in rejecting a scarcity mentality. I think it's really easy in medicine to get into a competitive mindset where if somebody gets something, it means you don't, or that someone else's success is your failure. And in true Michigan fashion, both Dr. Dimmick and Dossett are the team through and through. So I've really learned from them rather than trying to keep my idea secret and wait till it's perfect and I have all the publications, that you get so much more if you share it and invite people in, and I'm really grateful for their continued leadership in this regard. So ultimately, the curriculum remains a work in progress, but we hope that it can be a powerful tool for ourselves and our patients and that it will continue to grow and spread. And with that, I'll hand it over to Dr. Dossett to discuss a little bit about the cases themselves.
So thanks, Chelsea, just for giving that great overview. You know, in the interest of time, we didn't feel that, you know, it would be possible to go through an actual case discussion. Often these discussions, I think, are best, you know, in smaller groups where there's more familiarity and trust. But what we did want to do is give a few examples of cases that we have discussed at our own institutions. Some of them are hypotheticals, but many of them are actual experiences, just to give you a range of some of the cases that we've discussed. So this first one, while trying to run a code, a female resident is frequently talked over and interrupted. She raises her voice and changes to a harsher tone and hears a bystander remark, "Wow, she's really pushy." So this was an actual case that was discussed at one of our institutions. Next slide.
Sorry, I forgot I had control.
This was a case that we had over the summer at Michigan. A white male patient was admitted with a bowel obstruction and refused to be cared for by a Black female intern in the middle of the night. He stated to the intern and the nurse that she was only recommended an NG tube because she herself was racist, and he made disparaging comments about the Black Lives Matter movement. And this was something that as a department, we struggled with how to, you know, we weren't prepared to support our intern, and we struggled with how to respond. And as many of you can imagine, you know, the early months of internship are stressful enough without having to deal with situations like this. And so having the cultural complications format to discuss this case was really impactful for our department. We were able to invite a number of leaders from our hospital. And one example of an action item that came out of this was, you know, a patient agreement on what types of behaviors will be tolerated. Next slide. This was another recent case that we discussed, a Black woman with a significant bipolar disorder and a breast cancer. Several days before the operation, began using the patient portal to communicate suicidal thoughts. And after being unable to reach the patient, the cancer center social worker called 911 for a wellness check. 4 police and SWAT attire arrived at the patient's house. The patient feared that she would be arrested, and this further complicated the trust in her care team. Again, a difficult situation with lots of implications for our patient and our providers, and something that, again, we're thankful for having the forum to discuss. Next slide. During morning rounds, the surgery team is going over the discharge plan with a patient who's had recent bariatric surgery. One of the team members remarks, "I know patients like you don't usually love to exercise, but it's very important to get up and walk frequently once you get home." So again, a case of obesity bias. After a prolonged ICU stay, during which time hormone therapy was not administered, a transgender patient starts regrowing facial hair, and the ICU staff becomes more lax about using preferred pronouns. As Chelsea alluded to in her introduction, and at Michigan, both of our centers have significant gender affirming surgery programs, and this is something an issue that we face with our staff and our providers. So these are some of the examples, again, that we've used at Michigan. We're about 18 months into deployment of cultural complications. I would say now it's a rather automatic and integrated part of our culture, and we're mostly doing new cases that, you know, actual cases that come up, but we would be happy to answer questions about our deployment and look forward to the panel.
Thank you, Dr. Harris and Dr. Dossett. Thank you for really a great overview and an excellent presentation. I know there's certainly a desire and a number of people on the call to actually get into walking through these cases. But I think you're highlighting, Dr. Harris, your journey and where you began from, but also your willingness to learn and have us understand how this is an essential part of the world we live in to really be foundationally outstanding and successful for both training and taking care of our patients was really apropos. And then Dr. Dossett, these case presentations remind us that on a daily basis, just like in the care of our patients, mistakes happen. And we make sure in our best days to not look over them so that we don't repeat them again and learn from them. So I think this example of the tons of mistakes that occur in our culture, we've ignored and brushed off as if they have no consequences to the psyche of performance or behavior of our patients, our faculty, our house staff, and our staff and employees. I think it has a huge impact. I think likewise, having the ability to recognize and make the effort to not be repetitive in those mistakes is huge, and it's important, probably even more so now than ever. So again, thank you for the timely presentation and just some of the examples, and we can probably come up with a number of them, both macro and micro areas of actually mistakes and aggression that we can put on in our thoughts about what we would like to be able to speak about. I think I have one question to ask for both of you, and then I'll ask Cappy Ratcliffe and offer Colin and Herb a chance to comment, but her to go through questions if there are questions in our chat session. So what do you do for the person who is in this setting of a cultural complication? It's a real case that they have now revealed about their own struggle. How do you manage sort of having them bear an open wound and deal with the fact that they have to go back and daily work in an environment that they're not sure will be any different? What's the strategy around both not only exposing the challenge, but obviously one of the goals around an M&M conference is to come out with what's the right thing to do. And a lot of that right thing to do usually typically is individually driven, but sometimes it's systemic, right? Some of the complications are driven because there's a systemic problem in the institution, and it takes a bigger group of people to actually solve that systemic issue versus just a physician who made a bad choice or a decision with a complicated patient.
Yeah, I can start with that. I think that's a great question, and certainly probably the biggest challenge we faced is that at the end of the discussion, we haven't solved many of these problems. I think the things that we have seen, the tangibles that we can take away, number one, probably the first 6 months or so was so impactful to be having these conversations and see the number of people that would speak up and say, yes, this happened to me here last week, and I think number one, it educated our faculty, our residents, our students, that for those who weren't impacted by these issues, that these were things happen in our own culture. And I think by definition, alerted people to be allies for the next time. So they start to recognize just with medical complications, as we're exposed to them, we start getting into pattern recognition. And then the next time we're able to step in and be, an upstander. I think that's been one thing. We have had a couple of the more sort of significant events where we have, just like we might with a medical error, form, root cause analysis team and continue to work on that topic. There have been a couple of the topics that, we felt were so significant that warranted that sort of continuing team and focus on some of those issues.
Chelsea, how have you found this in the culture of your residency? Obviously, we're often talking about sometimes at a faculty level, but in the residency, how have you found this to impact and potentially have a positive impact on your resident community?
I think there's several elements of it. I think even one step before this, we just completed our general surgery interview cycle, and the level of cultural competence, or how is your department addressing some of the bigger conversations that are happening nationally? How do you approach recruitment, et cetera, are conversations that trainees are looking for. That's something that people who are getting into surgery or getting into medicine want to know that you're doing, and that you're trying to evolve your department and your group. And I think having something like this to point to is a really powerful signal to what you're trying to build at your institution and to recruit other people. I think at the resident level, at certainly some of the patient-facing aspects, we're probably along with the nursing staff, the ones who experience patient-directed microaggressions at the highest level. And so having an area to both to affirm that other people, just as Dr. Dossett said, that other people are experiencing this and that you're not alone, can be a really powerful, just the awareness raising as well, but also having a script. I think what often happens in responding to microaggressions or any of these common things that we face is you're caught so off guard that, half an hour later, you're like, oh gosh, I really wish that I had said X, Y, Z, but you don't necessarily have it right in the moment. And having these public discussions in here, maybe who's someone who has been through this a couple more times than you have, and this is what they have said, or this is what they do about it. We have scripts all the time for whether it's talking about risks in our consents, or if you have a patient who's perhaps not speaking to you with respect, you start developing, or a family member who wants an update, you have these kind of go-to lines that you say over and over again. And by creating a similar formula for instances of cultural breakdown, I think it allows people to respond with a much higher degree of fluency than they may have already had.
Colin, how is this rolled out in the Department of Surgery?
Thank you for that question. Again, thank you, Dr. Harrison Dossett, for all the work you've done. The rollout's been pretty smooth, and a lot of that is due to not only the curriculum, but also speaking with Dr. Harrison Dossett offline, just to anticipate any pitfalls. Before each cultural complications M&M, we have a pre-meeting, and in that pre-meeting, there are several members of our faculty, including our chair. And it's not to make it scripted or inauthentic. It's just to anticipate any pitfalls or areas where we might have blind spots. And the pre-meeting has been really good. I think the biggest thing is that we've been able to create a safe space where residents, faculty, male, female, et cetera, feel comfortable speaking. And that's really attributable to our moderators who are doing a good job asking questions and keeping the conversation going.
Yeah, I don't think you want to have one of these and actually people come out feeling worse than when they started, which I'm sure could be an unintended consequence for sure. Herb, any comments? And then I'll ask Cappy to see if there are questions.
Yeah, I'll just again acknowledge Chelsea and Leslie for their work, because I was tentative about how we were going to roll this out successfully, and credit Colin for really thinking about it and getting people engaged beforehand. The pre-meeting is key to select the right cases, knowing that you're going to try to select cases that are potentially applicable to more people in the beginning, to develop some trust around the process and engagement. And then obviously as we progress further, we'll take a little more risk as we move forward, but at least to choose things that potentially everyone would have experienced and acknowledge, and then to start the discussion there. And I think to have an engaged moderator who asks people to comment. Those are some of my thoughts, but it's been fantastic. I mean, if it was, I have to see how positive has been in our department and how well it's been received, better than I ever expected. And the engagement has been really, really fantastic.
Good. Cappy?
I'm here, and I'm just looking at the questions in the chat. So you guys have actually covered a lot of these already. I do have one that says, we all try to avoid microaggressions and stereotypes, but we are all influenced by cultural representation bias. When we do say something stereotypical and biased, is there a preferred strategy to respond in addition to apologizing profusely?
So I will say, I think one of the issues in a lot of this is we don't always know where our blind spots are. That's the definition of blind spots. And so the first goal of the cultural complications curriculum is to figure out where those are and what they might be. And I think you might be really good, like my journey, I was pretty well versed in the gender disparity things, but as I got broader, I learned all the other things: obesity bias, ability bias, many of the conversations around race and ethnicity. I didn't have the language and I didn't have the comfort level to engage in. And so learning and getting perspectives outside of yourself are perhaps one of the most effective ways to just avoid doing it in the first place. And this is one of the areas that I've found that social media has been tremendously helpful for me, that I can deliberately follow, docs with disabilities or prominent leaders in areas that I had no idea what the experience was, because I just wasn't interacting with anybody who had that perspective in my day-to-day life. And so I've broadened my perspectives beyond that. I think the other real cornerstone of this work is knowing that you're never going to get rid of the first reaction. Our brains are hardwired to have stereotypes and terrible first reactions on a whole host of things. But you can work on how you respond to those and just take a step back and recognize, did I have this negative reaction or this stereotype? Like, am I having that? Could I change how I respond to it? A classic one around gender is if a woman's being pushy or bossy, you're like, ugh, I don't like this. And then you step back and be like, wait, do I not like this because she's being authoritative and I'm kind of taught that women aren't supposed to do that? Or is it she's actually being a jerk? And sometimes she actually will be being a jerk, but to have that conversation with yourself, I think is a really important one. And then the strategies that I've used, I did this the other week. I made a joke that I didn't think I walked away and I was like, oh, I wish I hadn't have done that. So I went back to both of those people and I was like, I wish I hadn't made that joke. That's not the sort of person that I want to be, and I will try to do better in the future. And if you didn't take it poorly, wonderful. If you did, I'm really sorry, and I'll be a better person the next time around. And I think you just name it, and then you have to walk the walk. Then you have to not make that joke again. But that's sort of how I approach it.
Another question is, how do you better prepare patients and strengthen their understanding of what appropriate care should be?
Yeah, I think the patient-facing ones have been really a challenge for us to address and contend with, because obviously we're taught, to put the patient first, and to some degree the patient's, are always right, sort of a customer service type approach. But as some of the examples that we shared, that's not always the case. And particularly as I think what we've seen as we have made improvements in creating a more diverse, faculty and resident complement, now we're facing issues that we hadn't previously faced when we had no Black residents, for example. And a few of the challenging things that we've come up with is oftentimes, your sort of protective instinct is to remove that resident from that experience. But that's not always what they want, right? They don't want to be excluded from the team. They want to learn just as their colleagues are. And so really, I would say we've dealt with this on sort of a case-by-case basis, making sure that we're supporting the staff member, whether it be resident or, as Chelsea mentioned, oftentimes it's the nurses who are subject to some of this behavior, and that we're engaging them in it. But then also that we have strong allies on the rest of the team. In a couple of the situations, these patients had had these same experiences or behaviors at other hospital systems. So not, just firing the patient, so to speak, was not going to be helpful. So it's continuing to engage with the patient, set expectations, have allies, and making sure that you're taking care of your team members, I think, are some of the principles we're working on.
Have you two, I'm sorry, go ahead, Dr. Harris.
I was also saying that's we sort of look to our attendings sometimes to be the protectors and the removal things, but I think there's also some really powerful help that can be at the same level or even going up or down. So, if we return to a gender example, if the chief resident isn't recognized as leading the team and the male medical student is able to say, actually, she's the boss and I look to her to run the team or something along those lines. Or if you have someone, who isn't necessarily in the direct line of fire, so to speak up and say like, that's actually not the language that we're going to use when we speak to each other. That can also be a really powerful way. And that doesn't remove anyone or make them feel like they're less of the team. It makes them feel more supported and more part of the team.
One or really several questions have been about making people feel comfortable asking questions in this, on how it could make them feel uncomfortable and how we want to make them comfortable. Have you all used polls to query audience regarding how they would respond or speak up, talk privately, say nothing? And kind of how has that gone? Has that been a helpful tool that you think would work well with this curriculum?
Yeah, we've definitely used some polls for certain cases. And sometimes I think that the results are illuminating. The other thing, we had actually implemented this prior to COVID. We had been doing it about 6 months, so we were doing in person and then switched to a virtual format. And like Chelsea said, one of the actual advantages to the virtual format is the ability to send, make private comments through the chat or anonymous, questions and things. And so some people that might not have felt comfortable speaking up in an in-person format have that ability to contribute to the discussion. I think the other, a number of questions about how do you make the people who are presenting feel comfortable. I don't have a great answer for that other than just do it, set a date and do it. We sort of drug it out. We had the curriculum built for probably 6 months before we actually implemented it, and had a couple incidences at our institutions that forced our hand a little bit. And it's uncomfortable the first time. We have a great chair who is an ally, introduced the session and sort of set the tone, but it's uncomfortable, at least introducing it. But that being said, Chelsea and I have, we've obviously done a number of these at our own institutions. We've given these similar talks and done cases at many institutions across the country. And it's one of the easiest, in my opinion, discussions you will moderate, because there are people want to have these discussions, and people speak up, and people speak up across the hierarchy. So in a traditional M&M, you would normally mostly hear from the senior faculty who have all the clinical experience. But what we found is that our students are engaged in these discussions, our residents, and you really get the full spectrum of comments.
And I think if you build out beyond the curriculum as well, one of the best ways to get people to feel more comfortable is to give people more knowledge. And so if you give people the tools of how, like when I was first getting into this space, there was a lot of areas I was really worried that I was going to say the wrong thing or do the wrong thing, and that was going to turn everybody off, and I was going to wreck all of the goodwill that I had tried to build up. And so I think, one, acknowledging that fear and making sure that this is you establish that it's a spirit of learning. But also, one of the things that helped make me feel a lot more comfortable is when I started actively seeking out other perspectives and learning more about the area that I was going into. And then I knew what some of the trouble things were to avoid. And you don't have to have the same people who experience the discrimination do all of the education around it as well. You're taking on some of that ownership and learning for yourself. And, it's not going to be clear cut in every situation. For example, I've learned a lot in the docs with disabilities community. There's some people that really don't like the term disability, and there's some people who say this is how I describe myself. And so you're not going to necessarily always have the perfect terminology for every single person, but I now know that that's the case, and I can make sure that I'm a little bit more sensitive when talking about those sort of issues and when interacting with patients who may have different kinds of physical or mental disabilities. And so that has helped me tremendously.
Thank you. Dr. Harris, you mentioned early on about how you kind of gave a disclaimer about being a white woman having this focus. Are there unique challenges that you guys, the two of you, have faced in this field of study, being two white women? really tackling the issues of some of these important issues rather.
Certainly. I think we had, I'm working on broadening the team, partially because it's hard to administer this as a senior resident, period. And the more help I can get, the better. But like I said, I reached out to various members of my department and said, hey, this is what I'm working on. I would love your input. If you don't want to be part of it, that's also fine. If you want to review it in private and give me feedback on what you'd like presented, I'm happy to do that. I tried to make it as open as possible. It could be very possible that there's people in the department who are sort of rolling their eyes and thinking I'm not hitting the nail on the head. I accept that reality also. But I think really trying to broaden the team. The part that I was sensitive about was because, as I mentioned, we had a fairly chilly reception at the beginning, and that has since warmed a ton, but I didn't want to put anybody else in the line of fire who didn't necessarily want to be there, whom I've already felt like they were having to struggle with their identity at work. And so that was the tone that I took. But it's something that I'm constantly reevaluating and that I feel a tremendous amount of anxiety about. And I hope that if people have comments on how we can do better, that I've created a space where they can tell me, and then I will begin the hard work of doing that.
Thank you. One question is, how do you manage if patients treat you with racist comments or give you negative comments in feedback forms, social media, etc., because of the provider's race or gender?
That's a good and hard question, I think, and one that probably exceeds the time limit we have here. But one of the things that we've talked about a lot, and use talking about scripts and things, is particularly with patients or in these scenarios, one of the things one of the phrases that I use as a script is from furious to curious. So using the instinct of asking a question, what did you mean by that comment? Or can you explain to me what you meant when you said that thing? Often serves to sort of, in the moment at least, to disarm or to lower the temperature a bit and cause some rethinking. So that's at least a strategy in the moment, in the short term. I think other things like evaluations and forms and patient satisfaction forms. I think clearly, as we've seen in educational things, those are ripe for bias, and we have to consider how we use those as institutions. But at least in the moment, those are some tips.
Yeah, I think as we've talked about, dealing with the patient-facing parts is by far some of the hardest. And I think one of the other parts we alluded to a bit is that it feels like at least in my experience, a lot of this is really at the below the identifiable as sexist or racist. You're like, I really have a feeling that this person is treating me differently because of how I look or because of how I sound or because of some aspect of my identity. But it is so hard to prove that. And so one of the things that's helped me in that is getting a sense of community and having my co-residents around to affirm, like, yeah, that sounds like they were being sexist, or it sounds like they were doing whatever, or I can do that for someone else. And that's really helpful. Most of our interactions, at least at the resident level with patients, are transient. And so a lot of it's just getting the support through that initial part, and then you can move on and have something that's a more positive interaction, but not letting that one sink its teeth in and stay with you for the next day and the next week and so forth. I think that's really what we're trying to do is you're not necessarily going to fix all bias in your patients, but you can mitigate how that bias carries into the rest of people's clinical and work experience. And I think having a strong community is one of the best buffers to that.
Do you have a behavioralist and historian on your team? either of you?
We do not. So I made most of the PowerPoint curricula based largely on research, and then some of it was supplemented by social media and podcasts and things like that. Like I said, I've tried to send, as I got out of things that I was quite as familiar with, I tried to send all the PowerPoints to content experts to get their feedback on it. And then we have a survey specialist as we're starting to develop the research arm of this. Both Dr. Dossett and I have qualitative backgrounds as well, so we're hoping to develop a qualitative arm once I get the IRB together. And we're certainly looking to expand, particularly as this continues to grow. I am more than happy to have new people and different perspectives on the team.
Yeah, I'll just say that similar to clinical complications, if there's an expert that we feel would be useful discussion. If we're talking about a surgical complication in a pregnant patient, we might invite an obstetrician to be part of the discussion and contribute their expertise. In a similar way, we often will invite relevant content experts to be part of the discussion who might be outside of our department or even institution.
Dr. Martin and Dr. Chen, do you have any barriers that you have had to work through that you haven't already touched on that can kind of encourage those out there who are considering implementing this in their institutions or in their departments? Any advice? I see Dr. Dossett is someone in the chat asked about implementing this at their institution, and so she's responded to that, so that's excellent. Any advice for those moving forward who are planning or hoping to adopt this?
Yeah, I'll just start. And I saw a question that came through about the pace of change, and I would say that it's going to be somewhat slow and incremental. After just 2 sessions, we've seen progress, but I anticipate 6, 7, 8 sessions from now, the progress will be greater. And so I think just understanding, we've been really careful about selecting our cases and gradually easing into the cases, and that's been really helpful for us. But I think just sort of anticipating that it's going to be a slow, steady cultural change that we're hoping to implement.
I would say that, I'll volunteer Colin to help any department at UAB who wants to do it. But I would say the strategic decisions I think Colin and the group has made is to we devote an entire session so we have usually 3 or 4 cases within the 45-minute period, and we do it monthly. So it's regular. So to keep moving forward, I think as Chelsea pointed out in their talk, things that only happen once a year are not really that effective. So while the pace could be slow, I think, once you get some momentum, I would imagine that the pace will accelerate.
There's one question that just came in. Do you invite non-faculty members of your department to participate actively, like administrators, nurses, techs, PAs, etc.?
Yeah, so our M&M is open to whomever wants to attend it. It is at 6:30 in the morning on Thursday, so that may limit the excitement of people in other places. But I think a really important expansion of this is going to be into nursing communities. I think the data from the first trial shows that nurses are one of the biggest sources of gender-based discrimination for female surgical trainees. And that's certainly something that I've experienced in my personal life. And I'm sure, just because I'm not reading the nursing literature as much, there's similar aspects that they're contending both with physicians to nurses and patients to nurses that also have a tremendous impact on their day-to-day experience. So I would love to start creating a community around this that's more like, let's be teammates on this rather than let's be adversaries, which is often how it sometimes ends up.
Abby, I think that's an example, I think, where this may differ a little bit from just being completely department centric, because the culture and environment that affect both the physician and nurses and faculty include more than just the doctors. And so I very much think that in some scenarios, having nursing participate, having, you know, people in environmental services, in food services, who may or may not, but may have had similar encounters that they have had very few people to tell their stories to. So I think broadening it, because if it's really about the environment that allows people both to heal and to grow, you got to deal with every part of the environment. I realize our time is about up. Am I right, Kathy?
Yes, sir. Unfortunately, it is.
Well, I really want to thank you, Dr. Dossett and Dr. Harris, for taking your time. And again, as Dr. Chin said, we owe you all both a visit to Birmingham. But thank you for your passion and hard work and your courage to get this started in your own institutions and to speak around the country about it. And thank you, Colin and Herb, for launching it at UAB. So thank you all again. And hopefully as we expand it, many of our departments will take this as an opportunity to move toward addressing not only medical complications, but cultural complications. Thank you.